inflammation will happen as your body attempts to basically fight it. And then when your immune system is fighting the infection, some waste will be produced as well. So this can be some dead cells, some of the bacteria and fungi. After your immune system has been fighting it, some of the waste products are produced, and they can sometimes collect in an area of the brain. And then tissue will grow around that collection of waste material, and that essentially will form the abscess. And the abscess can swell and put pressure on your brain, so it's a medical emergency and can be life-threatening if it's left untreated. So some of the symptoms. Um, Similar, a lot of the time with neuro things, you can get these common symptoms. So you can get headache, fever, seizures, numbness, weakness, or paralysis, and cognitive changes. A lot of the time with brain abscess or metastases, it depends on where in the brain it is. So if it hits in the motor cortex or the sensory cortex, it can have some weakness, numbness sensation. If it affects more the frontal part, it can be cognitive changes, that kind of thing. So it depends on where the actual abscess or lesion is, basically. That can cause a lot of the symptoms. In terms of diagnosis, there are a few things. So you can have a neurological exam again to look at the actual symptoms. So any motor changes, sensory loss, that kind of thing. You can have blood tests, EEG, to see if there's some kind of infection, to find out what that could be. And you can have images. So this is a CT scan here, and it shows a ring enhancing lesion. So you can see in this lesion, the kind of around it, it seems a bit more enhanced and brighter. So that's one of the key features of a brain abscess, is a ring enhancing lesion. It's good to remember that. And you can also get a biopsy as well to identify the cause and type of infection for treatment. So that's quite useful when you're actually thinking of treating it, to find out what the infection is and the kind of primary cause of the abscess. So yeah, treatment. So you can get medication. So you can get antibiotics and antifungals. So it's good to have the biopsy so you can see which kind of what infection you're dealing with here, so you can get the best medication choice. And in certain cases, you can also have surgery. So you can get needle aspiration. So it's basically kind of sticking a needle in, kind of slowly aspirating out the abscess, kind of just removing it. Or you can get a craniotomy as well. So you can kind of surgically open the brain and then kind of take out the abscess. That can be done as well. Okay, onto meningitis. So this is basically inflammation of the meninges, as I mentioned. So this can also be bacterial or viral. So I think the most common is bacterial, most common cause in the UK at least. So a lot of the common causes, so it can be Streptococcus pneumoniae, Neisseria meningitis, I'm not going to be able to say these right, meningitis, Haemophilus influenza, and Listeria monocytogenes. And viral, I think, is mainly herpes simplex virus and HIV. You can also get meningitis from tuberculosis as well. So it's those three main kind of bacterial, viral, and tuberculosis. Those are the three main causes of meningitis. So the symptoms, there are some kind of telltale classic symptoms for meningitis. So you can get sudden fever and a stiff neck. So if you get a stiff neck, that kind of is often meningitis or also encephalitis, but those two are kind of the main like infection of the kind of parenchyma and the outer meninges. So you can get a stiff neck, sudden fever, headache, nausea, confusion, and seizures. You can also get a skin rash depending on what is the actual bacterial infection. So it's meningococcal meningitis is what that's referred as. For diagnosing, you can have a few things. You can have the physical examination, which is kind of where you can notice the stiff neck and that kind of thing as well. You can have some blood tests to find out what the infection is. You can have imaging, which is mainly MRI. I think that's the gold standard for looking at meningitis. But the key diagnostic tool is lumbar puncture. That's the gold standard. Essentially, that will confirm it's meningitis and will confirm exactly what the cause is. So if it's bacterial, viral, tuberculosis, it will give you the exact picture. And that's kind of the gold standard of what you kind of have to do to know if it's meningitis, basically, just to confirm it before you do any treatment. Although you can do treatment before as well, but that's like the best way to confirm exactly what the diagnosis is lumbar puncture. So remember that one. And then treatment, you can get antibiotics and maybe corticosteroids, so if it's bacterial. And then and for viral, it's mainly just rest and pain medication because there's not really much antibiotics you can give for this. Okay. So surgery. So yeah, meningitis in itself, you probably won't have any kind of surgical procedure related to it in itself, but you can get hydrocephalus, which is kind of like an excess CSF from the ventricles. So ventricles are kind of like an internal structure where the kind of CSF is stored. So if you get a lot of CSF buildup there due to meningitis, then you get hydrocephalus, and then with that, you'll need to get a shunt. So there are a few options, but in this example in the diagram here, this is a ventricular peritoneal shunt, so VP shunt. So basically, It's got a VP shunt here from the ventricle going all the way down to the peritoneum here. So this drains the fluid, the excess CSF fluid in the ventricle down to the peritoneum in the abdomen, and then this will basically, because then in the peritoneal cavity, it can be more easily absorbed there. Because remember that in the meningitis, you have the arachnoid granulations, which then kind of transfer it through so it can get back into the circulation. If there's inflammation there, infection there, then it is probably more difficult to pass, so it builds up, which is why I create the passageway down to the peritoneum so it can be more absorbed back into the circulation again. Okay, now on to encephalitis. So this is inflammation of the brain parenchyma. So before we looked at the actual outer layers of the brain, now we're looking at the actual brain itself, the brain tissue. So this can also be viral or bacterial, and then that would be referred to as infectious encephalitis, or it can also be from your immune system, and that's autoimmune encephalitis. That's kind of the immune system doing it itself. So some of the viral causes are herpes simplex virus. There are also other herpes viruses that can that can cause it as well. So you got the Epstein-Barr virus and varicella zoster virus, and you also have some enteroviruses as well. I think the main one is herpes simplex virus as well, so key one to remember. So basically, infectious symptoms is more of an acute situation. So if it's acute, it's more likely to be infectious, basically. So you probably get a headache, fever, a stiff neck again, confusion, seizures, and this is a bulging fontanelle. This is often seen in infants. You can see this kind of point here, soft spot. This you see this bulging. So if an infant has encephalitis, you may see this situation as well. And autoimmune symptoms are more chronic. So you can get personality changes, memory loss, hallucinations, and seizures as well. So there are differing symptoms, and they kind of tell you whether it's infectious or autoimmune, depending on acute and chronic. Okay. Yeah. So diagnosis, again, similar blood test, imaging, but lumbar puncture is probably the most important one there as well. And then for treatment, you can get antiviral medications. So cyclovir, the main one, you kind of go to for viral encephalitis. And they can also have some medication targeting the immune system for autoimmune encephalitis. So that can be corticosteroids or IV immunoglobulin. So those are the main kind of treatment things. There's not really much for surgery in terms of encephalitis, to be honest. It's mainly just medications. Now, in terms of imaging, so I thought it'd be good to kind of cover this as well. So this is an MRI scan of meningitis, and this is for encephalitis. MRI is superior to CT scans for identifying these conditions. You can see a lot more of the detail. So for meningitis, one of the key things that you can kind of see this thin linear enhancement of the meninges surrounding the brain. So that you can imagine the meninges lining the entire surface of the brain. So you can see even like the kind of gyri sulci of the brain, like the fissures, they're kind of, you can see the linear enhancement there as well. So that's one key sign of meningitis is there. Whereas for encephalitis, it's more of like a deeper brain structure that's affected. So in comparison, meningitis, outer meningeal layers, encephalitis is more of a deep internal brain structure that's affected. And often there can be like involvement of the temporal lobe in this area. So that's often, in more of the common cases of encephalitis, you get temporal lobe involvement as well. That's key to remember. Okay, then we have metastatic spinal cord compression, also called MSCC. This is basically similar to brain metastasis. So this is when cancer spreads to the bones or tissue that surround the spinal cord, and that can cause compression of the spinal cord, which is very dangerous. And this is common in people with breast, lung, prostate cancer, and myeloma, which is blood. Yeah. I'm getting mixed up with myeloma and melanoma. But yeah, myeloma is blood. I think melanoma is probably skin then. Yeah, skin cancer. So yeah, you can see here a little tumor here, and it's kind of causing the compression of the spinal cord. So symptoms. Again, it will depend on which part of the spinal cord is compressed or affected. So it can be higher up, can cause more of the symptoms up here with the arms as well. Lower down, it can cause more symptoms with lower limbs only and not upper limbs. So these symptoms can include bowel problems or bladder dysfunction, as you mentioned with the cauda equina. So kind of when you get like kind of nerve impingement or like compression at a certain point, normally all levels below that will be affected as well. So if it's higher up, you can imagine the arms and legs will be affected. Whereas if it's lower down near the midline, then it'll be more only just the legs affected and the arm will be spared. So you can get gait disturbance with like walking, difficulty walking, and you can get neurological signs, so numbness, paresthesia, sensory loss, or limb weakness as well. Okay, and for diagnosis, so you have imaging. So you can, I think it's mainly MRI, but you can use CT, but MRI is often better for looking at spinal cord pathology. And then again, since it's like more of a metastatic problem, so you want to do a CT of the chest, abdomen, pelvis, just to see what the primary cause of the tumor is, what the primary tumor is that's causing the metastasis. So you can try to treat that as well. And you can kind of see here, this is kind of where the tumor is. So it's here and it's causing an like it's compressing the spinal cord here, in this part. Okay, so looking at treatment. So immediate medication, you probably give corticosteroids because it's like kind of more of a compression to kind of reduce the inflammation there in that area. And you would get surgery for this case and like an emergency procedure because it's very dangerous when they do a spinal cord being compressed. So you can get decompression surgery to relieve the pressure basically. So this would be a laminectomy or laminotomy where you will, so you have the part of the lamina, which is kind of here, this part. So you can either get partial removal or full complete removal. So laminotomy is complete, laminectomy is a part of it. So here you can kind of see the entire lamina, so the lamina is completely removed here. And then here you can see it kind of just decrease the compression of it. So the bone, the vertebral body compressing it, open that out, and then there's more space for the spinal cord there. And you can also get corpectomy, which remove the entire vertebral body basically. And that's probably more in severe cases. And then if decompression surgery causes any instability, then fixation surgery or stabilization surgery will be needed as well. And that is basically when you kind of join the vertebrae using screws and rods. Just kind of it kind of limits movement a bit as well, but it's better than having like unstable vertebrae, which kind of causes pain and can cause more damage when you're moving. So that's more of the kind of surgical treatment that you get for that. Okay, I think we've gone through this faster than I expected. So onto the cauda equina syndrome now, nearing the end. So this is basically when you have an injury or a herniated disc which compresses the cauda equina nerve roots. So you, as I mentioned before, you have the bundle here, so you can just see this kind of bundle of nerves here. So when there's compression in that area, then it's cauda equina syndrome. And this is also a medical emergency, and it can be acute or chronic. So depending on, yeah, I'll go into that in a bit as well. So common causes for cauda equina syndrome, so it's herniated lumbar disc. You can get an infection, sometimes lower back injuries, so trauma as well, and also spinal lesions or tumors or lumbar spinal stenosis as well. But the main cause is herniated discs. That's a key one to remember. So the symptoms, these are some kind of red flag symptoms. When you hear about these, you would immediately first think, okay, cauda equina syndrome, and then you want to either try to cross that out and see if that is the case or not. And if it is, you want to get like an immediate action, basically. So symptoms are low back pain, saddle anesthesia. So that's kind of more of the kind of groin inner thigh area. And you get leg pain like sciatica or weakness and numbness. So it's mainly like saddle anesthesia and the urinary and or fecal incontinence or retention. Those two are kind of the main red flag symptoms. So when you see that, you would immediately first think cauda equina syndrome, and is that the case, and try to figure out if that is or not. And then as soon as you kind of see the red flag symptoms, you do an urgent MRI just to confirm it. So you can kind of see here the disc kind of herniation here, and then it's affecting the bundle of nerve fibers here, the cauda equina. So you do an urgent MRI. That's kind of a need to know thing. So like you get those symptoms, saddle anesthesia, and kind of urinary fecal incontinence. Get an MRI just to kind of see if it is the cauda equina syndrome. And then treatment. So you'd get like an urgent lumbar decompression surgery because of medical emergency, and I think if it's untreated, it can lead to long-term paralysis, basically. So you do want to try and treat it as soon as possible. So you do a similar decompression surgery as I mentioned before with the laminectomy or laminotomy. So you kind of just remove this part of the lamina here, and then that just kind of decompresses it and gives it more space to move around. And also you can actually remove the herniated discs. That's discectomy, the operation. So you can kind of see here is a really nice diagram. So this is the herniation of the disc, and you can see this is the spinal cord being compressed. And then you would use these small tools. So you can have these kind of keyhole surgery where you just make some small incisions and go in with these fine tools, and then just kind of cut out the kind of herniated part and remove that. And then you kind of just, so now this part here is fixed, and then it kind of just creates an open space for the spinal cord, the cauda equina, so there's no more compression. That's the main thing, basically. I think we finished about 10-15 minutes earlier than I expected, so I don't know if that's good or bad for you guys, but okay, I've got some MCQs for you guys now, so go to the first one. So I'll give you a second to read that question, and then you can just pop your answers in the chat. I don't think I can look at the chat like this, so if you could just let me know which which answers seem to be
Yeah. I
okay.
think
Yeah,
everyone is saying B, MRI spine.
yeah, yeah. That's the answer. So B. So yeah, the symptoms here do point towards Codd-Aquina syndrome. So it's a medical emergency. You want to do an urgent MRI to confirm the diagnosis. So well done, everyone. The other diagnostic tools are not really applicable to Codd-Aquina syndrome, so you wouldn't really do any of those. So the key thing here was to know that those symptoms point towards Codd-Aquina syndrome. So well done, everyone. Okay, question 2.
Yeah, we have a few answers coming in. They are saying A, arachnoid and PR matter.
So you got answers for A. Yeah.
Yes.
Okay. So in this case, let me just see if I get the answer right. Yeah. So in this case, the answer is D. So it's the periosteal meningeal dura. So if you remember, the dural venous sinuses are kind of between the two dural layers is where you have the actual venous sinuses, which kind of get the blood back to the internal carotid artery, internal jugular vein, sorry, then to the heart. So the actual venous passage is between the dura. In between the arachnoid and the pia, you have the like subarachnoid space with the CSF. You do have some vasculature there as well, some blood supply, but that's more arteries that are there. In terms of venous supply, it's between the dura, the two layers of the dura. So the answer here was D. You can kind of see here as well. So between the dural reflection here is kind of the superior sagittal sinus is up there. This one, superior sagittal sinus. Okay, next question.
Everyone's saying C, lumbar puncture.
See, yep, well done. So yeah, this fever, stiff neck, it kind of points towards meningitis, maybe meningitis or encephalitis. So the key standard there, the gold standard, sorry, diagnostic tool is lumbar puncture. So the other answers, so MRI can help with diagnosing, so it can kind of help to see what could be caused, what could be the kind of condition, but it's not the most important diagnostic tool because the question asked you is the most important one because MRI can tell you if it's meningitis probably, but it can't tell you the cause of it, whether it's viral or bacterial or tuberculosis, but lumbar puncture is much better at doing that. And the others, diagnostic tools, BDE, they're not relevant for meningitis. Okay, this is the last question I have.
Yeah, I think now we have answers for C, medial meningeal injury.
Yeah, well done, that's correct. Yeah, so yeah, epidural hematoma. So if you remember, the epidural is kind of in the it's in between the two dural layers, and then the dura is mainly supplied by the middle meningeal artery. So that's most likely to be involved in that kind of epidural hematoma. So yeah, well done. Yep, I think that's pretty much everything from me. This is some of the references that I used to make the slides. Apologies if it went really quickly. I may have underestimated how long it would have taken to go through these slides. I probably should have had more stuff, but oh well. And if you could please just fill in this, scan this QR code. So this will
Yeah.
register your attendance and also give you a link to feedback form, and then you can get a certificate from that as well. So
Yes. So, apologies everyone, because for previous sessions we have been using the Google form to fill up. So this said, moving forward, things will be much more easier. So if we appreciate if you guys could scan this QR code. So once you scan it, it should bring you to that feedback form. So we really appreciate if you guys can fill it up. That will mean a lot to Saim, and also help us know how we can improve moving forward. And after you have done that, a certificate should be automatically generated for you. Okay. If anyone has any problems accessing it, please do let us know now. You can either open your mic or text in the chat. Uh, Otherwise, again, thanks a lot, Simon. I really appreciate for the great session. And yeah, we are really quite early today, so send us to the career book form. Career book form. Um, Sorry, let me check and see. Yeah, I'm having the same problem instead of uh, it won't be towards a Google form, but is there any feedback? Because there should be a feedback link, like when is the having the same problem.
Is there a problem with the form?
There's a feedback link after you sign in. Yeah, right. Can you send the feedback link on this chat window? No, because there's it's through the QR code itself. Because um, yeah. Yeah, in the meantime, yeah, because we've ended quite early. If you guys have any questions at all regarding this session, like what Simon has covered for us today, like went through the anatomy of the brain, few layers, and then quite a few higher topics covered as well. So if you have any questions at all regarding that, or if you have any other general questions, I'm getting an error. Betul. Probably Roberto, may I ask if you could try to reload your page or try to use a different browser, or is everyone else facing the same issue as well? I got you. Okay, yeah, thanks a lot, Alana. Not so related to lecture, but Simon, I think there's a question
Yeah.
for you.
Yeah.
Uh, yeah, it's saying, are you able to see the chat or
No, don't think I
no?
can. Well, should I keep sharing my screen for the QR code, or should I stop sharing that?
Yeah, I think because I think some people might still
Yeah,
be needing
I'll leave it
to,
on.
yeah.
So
Okay.
can you just tell me the
Yeah, I'll
question?
read out the comment for you. So Robert says, not so related to the lecture, but are you enjoying intercalating in neurosciences? I'm definitely considering it, though I'm only in first year.
Yeah, that's a really good question. So I'm intercalating in Edinburgh. I think there are some differences depending on where you are. So I'm not sure where you're studying, but at least what I can say from my experience in Edinburgh, it has been really fun. And yeah, we've had kind of the first half of the year has been a lot of lectures and kind of tutorials and workshops. But the second half is kind of doing an honors project. So you can do a lab-based project or like an online kind of review project. So you basically do a bit of research as well. So it's really useful, a lot of good skills you can get from it. And yeah, I'm enjoying it. I think it's pretty good. Yeah.
Yeah, Robert says he's at Edinburgh as well.
All right. Okay. Edinburgh as well. That's great. Yeah. So honestly, I'd recommend it. Go for it. But I do know that in Edinburgh is quite competitive. So I mean, it's difficult to get into for neuroscience, but definitely go for it. If it's something that you're interested in, then yeah, because there's a lot of neuro stuff in it. A lot more the sciences side than medical side, but it's still really useful. Still really good stuff.
Mm. Yeah, he says thank you.
Yeah.
Right.
Anyways.
Okay.
Any more problems with the QR code?
Yeah. Any more questions or
Any questions? Oh yeah.
yeah? I think we leave it 1 more minute, then probably you can stop sharing the screen time.
Okay, that's fine. Yeah.
Yeah. If anyone does still face problem after this, yeah, do reach out to us. And yeah, I'll find a way to uh, uh, send over the QR code to you or the link if there's persisting problems.
Yeah, that's fine. And this is also just the last slide, so just looking at our socials. So if you want to follow us on Instagram or LinkedIn, then those are our tags. All right.
Yeah. Thanks a lot. Yeah, appreciate everyone joining,
Thank
taking
you
the
very much.
time to join this session. Really appreciate it and hope you guys learn something. So on Thursday we have another neurosurgery session as well, and that will be more PBR based, and slightly focusing on a bit different content, like focusing more on headaches. However, that session is meant to be a bit more interactive, and there are some crossover, which will kind of be a good revision of the things which Simon has mentioned today as well. So looking forward to see you guys if you guys have time to join on Thursday as well.
All right. Thanks so much, guys. Hope you enjoyed that.
Yeah. Yeah. Thanks everyone. Mm, there's a few more uh, attendees in uh, in the session, but I think does anyone else has any questions? If no, then yeah, I think we can end the session here today, Simon. Thanks a lot once again. And
Thanks so much.
yeah, the feedback responses, I'll send it to you after 1 to 2 days, just in case anyone fill it up a bit later.
Yeah, that's fine.
Okay.
All right,
Yeah.
great.
Thanks. Yeah. Catch up with you again. Bye.
Thanks so much. Goodbye.